Today's topic is the Acute Coronary Syndrome and STEMI care map. Health services across Manitoba are provided in facilities on the original lands of First Nations and Inuit peoples and on the homeland of the Métis Nation. Manitoba's health authorities respect that First Nations treaties were made on these territories, acknowledge harms and mistakes, and we dedicate ourselves to collaborate in partnership with First Nations, Inuit, and Métis peoples in the spirit of reconciliation. This presentation is intended as general information to broaden the knowledge base and informed practice of paramedics across shared health. The goal is to ensure paramedics can utilize the knowledge gained and apply it to any patient care map updates. We're going to be starting right from the bottom and building up throughout the presentation. A quick review of heart anatomy, the pathophysiology of heart disease, clinical presentations of these events, and finally the management of these patients. So prepare yourself. And this is the heart. We've all had the heart anatomy driven into our brain, so this is just a quick look to pull that dusty file out from the back, remembering the heart is divided into 4 chambers, with the left and right sides divided by the septum. The heart itself is sitting in a sac called the pericardium, and if we peel that layer back, we see the heart wall, which is made up of 3 layers, the epicardium, the myocardium, and the endocardium. Then we have our coronary arteries. The left coronary artery, which splits into the left anterior descending and the left circumflex. Then we have the right coronary artery dividing into the right posterior descending artery and the acute marginal artery. The acute coronary syndrome has a wide spectrum of disease, starting with angina, leading all the way to a myocardial infarction on the other end. The pathophysiology of acute coronary syndromes begin with coronary arteries, 2 processes called arteriosclerosis and arteriosclerosis. Arteriosclerosis is the change to the arteries generally seen in the advanced stages of life and those with diabetes. The elasticity of the vessels are lost, the walls become thick and hard, and the lumens narrow and may become obstructed. If this happens, the coronary arteries, the vessels are unable to dilate or react to increased oxygen demands, resulting in tissue ischemia. This is the common cause of angina. Arteriosclerosis is different from arteriosclerosis because of the presence of arthromas. These are plaques that build up on the inner lining of the vessels consisting of lipids, cells, fibrin, and cell debris. This will decrease blood flow and tissue perfusion in the same way as arteriosclerosis. However, the arthromas can break off and lodge in the coronary artery, completely obstructing blood flow, or a thrombus may become lodged in the narrowed area of the plaque buildup. First, looking at angina. Deficit of oxygen to the myocardium or ischemia when the blood or oxygen supply to the heart muscle is impaired during increased exertion or when the heart requires an increased demand. The concept of supply and demand is critical in understanding. Usually coronary arteries adapt to the needs of the myocardium by vasodilation. In damaged arteries, from arteriosclerosis or arteriosclerosis, vasodilation will not be able to correct the supply needed from the demand. Coronary artery vasospasm, or otherwise known as Prinzmetal angina, can also create a deficit in oxygen supply. This is typically found in females and can lead to infarct if not treated, usually very responsive to nitrates. The result of this decreased perfusion in the myocardium is pain and signs and symptoms of ACS. As the myocardium switches to anaerobic metabolism, lactic acid accumulates and CO2 builds up, causing pain. Typically, angina is predictable. The onset and the length of the episode is similar to events in the past, and the pain will go away after a period of rest or treatment with nitrospray, as perfusion to the myocardium returns and the supply is now meeting the needs of the demand. Angina is labeled as stable if everything is matching what the patient has previously experienced. Angina pain develops when there's an increased demand in the setting of stable arteriosclerotic plaque. The vessel is unable to dilate enough to allow adequate blood flow to meet the myocardial demand. Unstable angina is more severe. It indicates greater degree of occlusion in an artery or possibly the addition of a thrombus. It is described as a patient now having longer periods of pain or at a greater frequency or needing greater length of time for rest to have that pain dissipate. Pain at rest or at other levels of exertion that are usually tolerated are further indicators of unstable angina. We must also assume anyone with a new onset of chest pain is experiencing unstable angina or myocardial infarction, and we treat it as an infarct until proven otherwise. If we have a prolonged event causing ischemia, it will lead to a cardiac muscle tissue death or infarct. The myocardium becomes necrotic. Most commonly, infarction caused due to plaque ruptures or thrombus formation, but it'll occur due to a vasospasm in an already diseased vessel, due to a supply-demand issue when the lumen is decreased in size, or there is a reduction in overall flow from any cause, and this could be shock or arrhythmias. Typically, at the point of obstruction, an infarction occurs, and the surrounding area of ischemia and inflammation develops, and over time, in a wave-like motion, the necrotic portion becomes larger and larger, eventually becoming transmural or across all layers of the heart wall. These necrotic areas in the heart will produce changes on our ECG, and we'll need to determine if the cardiac event is a non-STEMI or a STEMI event. When infarct begins, it starts at the innermost layer of the heart wall, and it works its way outwards. The ring of tissue that is ischemic is still viable, so we need prompt recognition, coordination, and treatment to restore perfusion to the area. When the cardiac muscle begins to die, it releases myoglobin, creatinine kinase, and troponin into the bloodstream. Troponin is the main cardiac biomarker used in determining unstable angina from a non-STEMI. In unstable angina, there is no release of troponin as there is no infarct, only ischemia. In a non-STEMI, we have infarct, so we will see an increase in troponin. Normally, there should be no troponin in the blood or even only a small trace amount. Elevation is not immediate, and it takes a few hours to see an increase in troponin after an infarct begins. As you can see on this graph, there's a peak in troponin about 1 to 2 days post-onset. An NSTEMI, or a non-ST elevated myocardial infarction, occurs on the inner layer of the heart. We'll see a normal EKG, possible inverted T waves, or ST depression. Typically, an NSTEMI is less damaging to the heart than a STEMI. An ST elevated myocardial infarction is a complete occlusion of a coronary artery. Infarct is transmural or across all layers of the heart. This is where you will see ST elevation. We do not need any cardiac biomarkers to diagnose a STEMI. What we need are clinical symptoms as well as an ST elevation in contiguous leads on a 12 lead. So we all know what the typical signs and symptoms for an acute coronary syndrome are, but we're still going to list them off. There's chest pain radiating down that left arm, up into the neck and into the jaw. Really, we should consider any pain above the navel level. Any pain in the back, in between the shoulder blades. If they describe the pain as crushing, heavy, tight, sharp. If they describe indigestion or heartburn. If they're complaining of anxiety or experiencing that impending doom feeling, describing shortness of breath, they're diaphoretic, pale, complaining of nausea, vomiting, weakness, fatigue, palpitations, flutters, or vision changes. The signs can also be very vague, and there's always exceptions, especially in the female, diabetic, elderly populations. Symptoms can be atypical. They might describe a new shortness of breath or even just generalized weakness. They may even say, "I'm just not feeling myself today," and these could be their only signs. So we should always remain highly suspicious and rule out ACS. So how many people feel this way when they have to read an ECG at 3 in the morning? Correct 12 lead placement is essential in obtaining an accurate picture of a STEMI. This skill is very important, and the best way to become better is practice, practice, practice. This means doing a 12 lead as part of your assessment on most every patient. So when it comes time that you really need one, you will be proficient, because when you need to get this done, it needs to be done within 10 minutes of patient contact on an ACS call. Addition of a 15 lead may also be required for your patient. 15 lead gives us extra views of the heart where ST changes might be hiding. Ensure that the patient is lying down and still, and if you get a poor reading, repeat until you get a good one. See the baseline here? That's not okay. Baseline here, they're shaky. This is from muscle tremors. This isn't okay either. So keep troubleshooting until you get the correct one, a nice, flat, even baseline. You've applied your leads and printed off a nice strip. You've checked out the rate and measured out all your intervals, noting any bradycardia, tachycardia, heart blocks, etc. Now what are you looking for? For anything to be worth noting in regards to ST changes, we have to have the same changes in contiguous leads. This means these leads are looking at the heart in similar areas. First, we look at lead 2, 3, and AVF. These leads are looking at the inferior portion of the heart. You will see a reciprocal change in the lateral leads. In lead 1, AVL, V5, and V6, these leads are the lateral lead, looking at the left side of the heart. V1 and V2 are the septal portion. And finally, the anterior piece, which is lead V3 and V4. It is common to see changes in the septal anterior areas simultaneously. Reciprocal changes for the anterior septal area is the posterior. You cannot see the posterior without obtaining a 15 lead. V4R shows the right ventricle. The right coronary artery or the circumflex supplies the right ventricle. If there is ST changes in the inferior leads, it's a good idea to also check and see if there is a right ventricular involvement. V4R will determine this for us. And V8 and V9 shows the posterior portion. An isolated posterior MI is uncommon but not unheard of. And if there is ST depression in our anterior leads, do a 15 lead to check the reciprocal changes on the posterior. While the anterior depression can rule in a posterior STEMI, the positive STEMI on the 15 lead is a more superior diagnostic tool. When we are running our 12 and 15 lead, we are looking for changes in the ST segment. For PCPs, you're only looking for the prompt STEMI on the monitor, but of course, a little more knowledge is always beneficial. The ICPs have it a little more complicated to pick out a STEMI. During an end STEMI, observe for ST depression without reciprocal ST elevation, or T-wave inversions. T-wave inversions can be normal variations in some people, but always remember suspicious of an end STEMI. In a STEMI, we are looking for the ST elevation in any 2 or more contiguous leads. Not all elevation looks the same, so we are looking at the J point and measuring from the baseline. A situation that mimics the STEMI is a left bundle branch block. A left bundle branch block is characterized by a wide QRS complex and ST elevation in V1 and V2, and ST depression in 1 and AVL, V5, and V6. This can be patient's pathological normal, but if it's presumed a new onset left bundle branch block, meaning they're unaware that they have a block and it's not in their history, hopefully people know their history, but unfortunately not everybody does. If it is presumed to be new, treat it as a STEMI in the setting of clinical signs and symptoms suspicious of ACS. A quick review of what our pre-hospital goals are before we get into the management in more detail. We want to decrease stress, so don't allow those patients to walk or physically exert themselves. We want to reassure that patient using our calm voice and nature and removing any high anxiety bystanders. Let's decrease clotting, so let's administer some ASA. Increase oxygen to the myocardium. This might be by administering oxygen itself if their saturations are lower than 90. Pain control, including nitrates and opiates. and rapid recognition of a STEMI, gathering history, and making that appropriate transport decision. You should administer oxygen if the patient is a dyspneic or has an SpO2 of less than 90%. Titrate the amount using a nasal prong or an NRB so patient remains above 90%. There is no evidence supporting oxygen administration for patients who have a normal oxygen level in ACS. You can withhold oxygen for these patients who have a normal oxygen saturation. In acute coronary syndromes, ASA is the first line of defense, ensuring our patients do not have an active GI bleed or a true allergy to ASA. Get them to chew it ASAP. Chewing the tablet allows for a more rapid absorption than swallowing, so chewing allows the medication to be absorbed into the mucosa of the mouth. Dispatch usually instructs patients to do so, but let's confirm the expiry, the route, and did they chew or just swallow the ASA. And compliance to instructions. You can opt to either administer more or not. Also, never assume that MTCC has instructed the patient to take ASA, as we all know accurate information is not always obtained prior to arrival. ASA is an NSAID and is an antiplatelet agent. It inhibits the prostaglandins and COX-1 and 2 inhibition. At low doses, it has an antiplatelet effect at COX-1, and at higher doses, there will be an anti-inflammatory effect on COX-2. Our ASA dose is considered a low dose, so we will only be getting into the COX-1 antiplatelet effect. ASA doesn't remove the clot, but it stops it from getting bigger. And how does this happen? COX-1 initiates thromboxane to activate platelets and platelet aggregation. When we inhibit COX-1 with aspirin, this also stops thromboxane from activating more platelets. Let's talk about nitro. Administration of nitro doesn't look as cool as Nikki Sixx's flame guitar, but it's the mainstay treatment of angina and cardiac chest pain. We have the sublingual spray and the transdermal patch. Nitro forms free radical nitric oxide in the blood, causing events in smooth muscle and other tissues that lead to dephosphorylation of myosin light chains, resulting in vasodilation of the veins and arteries, but more prominently in our veins. There is a decrease in preload on both the right and left ventricles, which reduces cardiac oxygen demand. Afterload is also reduced, decreasing the work on the myocardium even more. You can simultaneously administer the spray and apply the patch as long as the systolic blood pressure is above 90. Don't hesitate to administer some IV fluids to increase preload and get the blood pressure up a bit to facilitate safe nitro administration. The spray will start to work in 1 to 3 minutes, whereas the patch is a longer onset of about 30 minutes. If you've applied the patch, you should still administer your sprays every 5 minutes. Spray once. Is there still pain? Let's spray again. Ask your patient, is there still pain? Let's spray one more time. Ask your patient again, can you quantify the pain? If there's no pain, great. Keep the nitro patch on as long as that systolic pressure stays above 90, and if it drops, simply remove it. If the patient is still in pain after those 3 sprays, move on to an opioid. You can still have the patch on, and remember that nitro has no limit for us in pre-hospital setting as long as the patient hasn't exhibited a negative hemodynamic response. Now let's look at the opiates. Morphine has an affinity to opioid receptors in the CNS and PNS. Everything slows down. We see a decrease in heart rate, blood pressure, and venous return, which can reduce myocardial oxygen demand. There is also a histamine response associated with morphine, which produces a heavier vasodilatory effect. Fentanyl agonizes the opioid receptors as well, but it lacks the histamine response, so it is a more hemodynamically favorable opiate. Fentanyl exhibits a decrease in heart rate and reducing myocardial oxygen demand, the same as morphine, but fentanyl has a much faster onset than morphine does due to being highly lipid soluble. Fentanyl effects is almost immediate when administering by IV, and morphine is a little slower. However, fentanyl has a quick off, whereas morphine will last longer. PCP's only choice is fentanyl in ACS, whereas ICP has a choice between morphine or fentanyl. The question reigns, which is the more superior opiate, fentanyl or morphine? The secret is they are equal in ACS. The key is to use an opioid. Some inquiries have been made into the morphine effects, the antiplatelet factors of ticagrelor, but multiple studies have determined there's no effect at all. There have also been multiple studies comparing fentanyl and morphine, and there were no statistically significant outcomes from any of them, concluding fentanyl is a great alternative. We still apply the same clinical decision making. Patients with lower blood pressure may do better with fentanyl approach. You may have a lot of blood pressure to play with, so you can opt for morphine. Or maybe use the faster onset of fentanyl to your advantage. Starting with fentanyl and switching to morphine for longer transports to utilize the long duration of action that morphine offers. It's kind of a choose your own adventure. Our goal of care in a STEMI is reperfusion of the myocardium. The clot must be removed that is causing the ischemia. The cornerstone therapy for an ST segment elevated MI is to achieve early complete epicardial microvascular reperfusion to minimize infarct size. Percutaneous coronary intervention, or PCI, is the preferred method of reperfusion. When PCI is performed in a timely fashion, it improves survival rate and it lowers the rate of recurrent myocardial infarctions compared to fibrinolytic therapies. However, there is a steep incremental increase in mortality when PCI cannot be delivered promptly. There is a bit of risk versus benefit occurring when we're deciding to treat with a medication versus a PCI. In Manitoba, we have only one facility capable of a PCI, and that's St. Boniface Hospital. A common term we all associate to this is the cath lab. If we're able to get the patient to the cath lab within 100 minutes from patient contact, PCI is preferred with the addition of further antiplatelet and anticoagulation therapy. However, if transport is over 100 minutes to PCI, there is too much risk in further damaging the myocardium, so we opt for fibrinolytic therapy, or TNK, prior to bringing that patient to the PCI procedure. I want you all to meet Jerry. Jerry is in Melita, which is in the southwest corner of the province and also home to Sunny the giant banana. Jerry is your patient. He has 8 on 10 chest pain with typical signs and symptoms of ACS. You've begun treatment and you've gotten a 12 lead. This is what you see: sinus tachycardia and no ST elevation. With Jerry, does he need reperfusion therapy? Not at this time. You continue your management and transport Jerry to the closest emergency department for further interventions. Keep in mind though, the 12 lead is not a one and done kind of deal on a call. While en route to your closest emergency department, continue to capture serial 12 leads in the event your patient hasn't developed ST changes yet. Sometimes the ST elevation takes hours to develop and we may be too early to see it. Now, if Jerry was presenting with the same signs and symptoms, but this is what you see on the 12 lead instead, we've got a lateral STEMI and we're in Melita. We know Jerry needs reperfusion therapy, but from the time of patient contact, we are over 100 minutes away from St. Boniface Hospital. Even if we factor in utilizing HEMS for a more rapid transport, we just won't make it to St. Boniface in the time frame. So we're going to take Jerry to the closest emergency department. So while en route to the closest emergency department, we're going to collect information from the TNK checklist that's found in Appendix A of the ACS and STEMI care map. You're going to relay any yes answers to the receiving physician, and this will allow them to decide if the patient is a candidate for pharmacological reperfusion therapy or not. There are hard and relative contraindications. First, let's review the hard contraindications. Is there any bleeding that is currently happening, an active internal hemorrhage, suspicion of an aortic dissection? Has the patient had any bleeding previous, or do we have the potential to cause bleeding? Have they had a stroke within the last 3 months, any prior intracerebral hemorrhage, any significant closed head trauma or facial injuries in the last 3 months, structural cerebral vascular lesions, or intracranial malignancies? All of these are hard indications, contraindications, in which the risk outweighs the benefit from not only increased risk of bleeding, but in mortality. There are ones that are more relative contraindications. Hypertension, direct contraindication with increased risk of internal hemorrhage. Hypertension is a relative increase in risk of vascular rupture. So if we have a systolic or diastolic above this at any time, we can let the receiving facility know, but this hypertension can also be corrected with medication. Traumatic or prolonged CPR, which is greater than 10 minutes, we're going to consider that there may be internal damage that can bleed uncontrollably if TNK is administered. Considering if the patient has any major surgical procedures or high-risk bleeding events, pregnancy contains an increased risk of severe bleeding independently. If they've had major surgeries, there is a risk of major hemorrhage from thrombolysis. Pericarditis, usually caused by local infection or damage to the myocardial wall. Damage is already in place and can lead to a free wall rupture with major pericardial tamponade. And do they have a true allergy to TNK? I really feel sorry for this patient if they know that they are truly allergic to TNK. TNK, or tenecteplase, will be administered as long as there are no contraindications from the TNK checklist. Expect this patient will be going on for a PCI following TNK treatment. TNK is a fibrin-specific thrombolytic administered via IV. This drug will dissolve the clot that is causing the STEMI, which will in turn improve blood flow and increase perfusion to the myocardium and reduce mortality. It will promote the initiation of fibrinolysis by binding to fibrin and converting plasminogen into plasmin. Fibrinolysis is a normal body process breaking down the fibrin that is holding the clot together. This happens as a result of plasminogen that is trapped in the fibrin mesh of the clot being converted to plasmin by TPA or alteplase. As plasmin is activated, it breaks down the fibrin and breaks up the clot. This is the normal process that can take several days to initiate. TNK is an engineered variant of alteplase. It's similar to TPA, but with a few mutations to make it have a longer plasma life, be more specific to fibrin, and have increased resistance to inhibitors. The time of onset of TNK is approximately 30 minutes with a half-life of 90 to 130 minutes. It really just kind of swoops into the clot, attaches to the fibrin, initiates a quick activation of the normal fibrinolysis process. TNK can be very successful and dissolve the clot prior to PCI. So now, what if we switch things up and Jerry's visiting a friend in Rose Isle? We arrive, he's complaining of ACS symptoms. We got the 12 lead, which indicates a lateral STEMI, and we initiate our primary ACS treatment. By ground, we are well within the time frame to get him to St. Boniface Hospital for a PCI. We can consider a HEMS intercept to get him to St. Boniface even faster, since our transport time there is over 60 minutes. So we've called a code STEMI. Now what does that mean? We call the cardiologist to arrange a bypass straight to the St. Boniface cath lab. Contact via MTCC to get the direct number to the cardiologist, or go through the St. Boniface Hospital paging operator if unsuccessful with the latter. Ensure you have the patient's name, age, and gender, current symptoms, physical findings, and the time of onset, a relative medical history and current medications, any allergies, and your current set of vital signs, including that 12 lead. Transmit a copy of the ECG via preferred method to the cardiologist. Often they'll ask for you to text it to them. Ensure no patient identifiers are on the image to avoid any FIA breach. When speaking to the STEMI physician, an option may be the administration of ticagrelor when we are transporting our patient directly to PCI. Ticagrelor is an antiplatelet, the same as an ASA, but instead of working to antagonize thromboxane, ticagrelor is a P2Y12 inhibitor. P2Y2 is an adenosine diphosphate receptor on the platelets, which plays a role in platelet activation. It recruiting other platelets to lesion sites and enhancing other platelet aggregating agonists such as thromboxane. So what does this mean? Ticagrelor inhibits P2Y12 from activating platelet aggregation on the platelet cell itself. The platelets roaming around won't be able to hang out with other platelets. So we'll have ASA inhibiting thromboxane from bringing platelets together, and ticagrelor inhibiting aggregation from the cell surface of the platelets. So it's a double attack. When ticagrelor is administered orally, it takes approximately 30 minutes for onset, and we do not administer ticagrelor if the patient is a candidate for T and K. Enoxaparin is an additional medication indicated when the patient is going straight to PCI. It is an anticoagulant given by IV. So check out your PCM for details on when it is given sub-Q versus IV, and this will be directed to you as the STEMI physician wants. It's a high alert medication, so we're going to ensure our double checks are done for our dosages with our partners. It's a weight-based and age-based dose, so ensure your math is accurate. Enoxaparin is a type of low molecular weight heparin and has immediate onset when given IV and a slower onset and a little less bioavailable when administered sub-Q. In the body, we have the anticoagulant cascade, intrinsic and extrinsic pathways leading to the common pathway. Factor 10A, when activated, causes thrombin and fibrin to come together to form clots. It is the end game of the coagulation cascade. We naturally have antithrombin 3 in our bodies. Without it, we'd be full of clots. Enoxaparin is introduced and it binds to and it potentiates antithrombin 3, and it becomes more powerful, and together they form a complex that inactivates the factor 10A. We no longer have the clot formation, and it further prevents the occlusion, and it prevents the current occlusion from getting bigger. We do not administer enoxaparin if the patient is a candidate for TNK. While en route to St. Boniface, make sure that you are regularly monitoring vital signs. This would include if you have the capability of a nasal end tidal CO2. Now is a good time to use it. It will definitely give you a picture of perfusion, and it will definitely indicate if there's a decrease in perfusion faster than that of a blood pressure. We don't want to get into more detail now. We do have an entire capnography presentation that you can watch later. If your patient becomes unstable at any point en route to St. Boniface, instead of going straight to the cath lab, you're going to go to the emergency department. So back to Jerry. You made it to the cath lab with him. Percutaneous coronary intervention, PCI, is the newer term that has replaced angioplasty with a stent. The procedure involves a catheter tube that uses a balloon and stent to reopen the coronary arteries. An angiogram is used to first determine where the blockages have occurred. A dye is introduced into the coronary vasculature and allows the angio team to visualize where the blockages are in the heart. This test can be typical for patients with angina or suspected coronary artery disease. In a stable situation, it is a scheduled procedure, but during a STEMI, it becomes more urgent. In this image, we can see a decrease of perfusion in the coronary arteries, indicating a blockage. So when the blockage is found, the cardiologist uses a catheter that has a tiny folded balloon on the tip, and it enters into the vessels through the radial artery and through the femoral artery. That'll be decided at the time of procedure. Using fluoroscopy, the catheter is threaded through the blood vessels until it reaches the site where the plaque is causing blockages. The balloon is then inflated, compressing plaque against the artery walls. This restores blood flow and the balloon is deflated and removed. A balloon angioplasty with stent, generally patients require something more permanent to keep the artery open, so a mesh-like tube will be threaded through the catheter and placed where the balloon was inflated. Once the stent is in place, they deflate the balloon and withdraw the catheter. The stent remains behind, and it opens the artery by remaining open. They will confirm treatment response by observing the reperfusion in the coronary arteries And yes, it's very satisfying, and Jerry is doing well and making sure that he gets his 10,000 steps a day. That brings us to the end of our presentation about ACS and the STEMI patient. If you have any questions at any time, please feel free to reach out to any member of the Westone Clinical team, and we'd be glad to have a chat with you. Thanks for sticking with us, and we'll talk to you later.